Quadcast Nation, welcome back. We have a very special episode. I have a good friend, colleague, co-founder, Dr. Brett Hryciw, fellow intensivist, future founder, creator, innovator, you name it. I'm going to call you Slash Brett. Well, welcome to the podcast.
Thank you very much. It's a pleasure to be here.
Absolutely. So we're talking to Osler. This is why we got you on the show, because this company, this movement is going to be big. It is a future to me within healthcare, but in other sectors, as we're going to talk about soon. But how did we come across this? What was the genesis behind Osler AI?
100%. So I think the way that Osler got started is there's just so much that rides on your ability to communicate with families. Like when you have a good relationship and you're able to have solid communication, everything goes smoother. And I think people feel better, care is better, you get more receptive feedback, just the whole patient care experience. And as a physician, you feel a lot more fulfilled when you're actually able to have a really good conversation and 100%. Have a really good line of communication.
100%.
And despite that, there's really not a lot of formal training. And so we kind of saw Osler as a way to sort of explore how we could help bring communication to the forefront of medical education and just put it back on people's minds in terms of, where we need to be focusing attention and resource. And I think it's particularly important now as medicine continues to accelerate. There's so much extra stuff happening in medicine. There's, so many new trials and discoveries, and medicine's advancing so rapidly. And I think we just need to remain grounded in communication as a core human element of the patient care.
100%. Like I always say to the kids being trainees, that your communication piece is what distinguishes you and what's going to make you a good clinician. Because most of us, you and I are in the same field. We could resuscitate somebody, we could save their lives, but it's the communication aspect that's going to make the experience different for the families, right?
Totally. And it sets people apart for sure. Like when you have a good communication and people trust you, like it's such a different experience than when there's tension in the room and the families don't know exactly what's going on and there's just this sort of divide. And so 100% communication needs to be a big piece of what we do.
Yeah, and even honestly, even when we're given, even if it's a negative outcome, like if you are an effective communicator, this is what the studies have backed this up, that this will still be a more positive outcome for the patient or positive experience, I should say, for that family if you're communicating well. And so I 100% agreed why we went on this path, but why do you think it's a challenge to get the experience? Like what? Because Osler is offering a solution to be able to, for people, clinicians to practice and so forth. But why is that a problem? Like what gap are we filling?
Totally. So I think one of the things, especially from a medical trainee perspective, is you spend a lot of time practicing these sort of skills in very artificial environments. When you're learning clinical skills, you're often in a room with 7 of your peers, plus a preceptor and a standardized patient. There's, quirks to it that, are very different than in real life. You have people like your peers are kind of judging and watching you. You have an evaluator that's there and they're grading you. And then the standardized patient, it usually does a really good job, but it's also, you can tell that it's, not necessarily 100% genuine. So I think for us, the ability to be able to take these conversations and bring them back home with you, so you can have these conversations anytime, you can practice, you can figure out these things, trial and error, decide what you want to say, how you want to say it, with no one watching, and it's just kind of you and a virtual standardized patient. Just de-risks the whole situation. You can start to have these conversations and practice and iterate and find out what works for you, and that's kind of the core thing that Osler's offering. And then there's just so many applications, which we started to realize over the past little while.
Yeah, and so just to walk it back a bit, so Osler, we see that there's a gap between how clinicians can effectively communicate. So we're going to try and create an experience where they can learn. So maybe even walk us through how do we do this? Is it on the phone? Is it in front of a computer? Is it in front of an avatar? How are they learning? Like walk us through the steps that would a clinician would experience doing this thing.
Totally. So right now, a lot of the learning, like I said, gets done kind of in these clinical skills sessions. what we're doing is we're trying to replicate that. So you log into a portal, you have your own account, you're able to have a conversation with patients that are drawing on kind of all of these different clinical scenarios that we've curated and brought that emphasize communication, history taking, counseling, and I think it's unique because when you get onto the platform and you click call now, you get this voice avatar that's talking back and forth to you and is adapting to what you're saying and has a backstory and has all of this information that it's trying to convey. And if you ask certain questions, it's going to pull new information out. And then not only are you having the ability to practice these conversations and be able to sort of find the words that work for you, find the phrases, find the delivery methods, the timing. You're also able to get a little bit of objective feedback, both kind of self-reflection when you listen to yourself, and also all of these objective sort of evaluations that we've been able to create as well.
That to me is the sexy part, is that you get feedback on your experience. So literally, if I'm practicing giving bad news to a patient after a cancer diagnosis, now Osler is telling me, hey, maybe you should take a little bit more time. Maybe you should allow a little bit more time for the patient to express their concerns. Getting that feedback, because what's beautiful about this, and listen, folks, I've gone through many exams looking at my communication, like artificial patient experience exams, and I look foolish. I've looked foolish many times. When I remember doing an OSCE, or this is what the formal term we use for these evaluations, and going saying like the patient got really sick out of a sudden. I'm like, well, this isn't awesome. And the the evaluator starts laughing. They're like, well, certainly your assessment, based on the assessment, that wasn't really awesome, and like just was referencing my answers, and this is in front of a bunch of peers too. So like it was uncomfortable and embarrassing. And knowing that I could do this now in the privacy of my own home, knowing that I could iterate and perfect or at least improve some of my communication skills, to me is huge.
For sure. Well, and the kind of crazy part as well is that a lot of the times you don't have a ton of opportunity to practice these things. Like the opportunity for these clinical skill sessions are relatively few and far between, given how important of a skill it actually is to curate, right, and develop. And so a lot of the real life kind of high fidelity practice you get ends up being on the ward. Like you're actually there having a conversation with a family member, and you sort of realize where some of the big holes are once you're in the situation, and it's kind of like too late to remedy that, right?
Yeah.
And so I think that's one of the other really impactful things is like from a patient care perspective, you have the opportunity to kind of like walk through these scenarios that maybe you haven't thought of, and have a dry run to figure out how you want to communicate stuff, how you want to deliver this information, how you want to approach things, be direct but not too blunt, like how you want to develop a bit of a bedside manner. And so I think, yeah, that's really kind of like the core offering.
Yeah.
That Osler is trying.
That's the magic sauce. Because like, I mean, even on a personal level, I've been on the receiving end through family about bad news, and if I'm receiving it in a crappy manner, that sucks. Like, just to put it frankly.
Yeah.
And sometimes it's not the fault of the kids. Like, they're, as you said, they haven't had much experience having to give bad news or navigating through a very challenging clinical circumstance. And so to be able to provide the trainees with a method that they could exercise this and work through it, this to me is genius. Because once again, you and I both know the way you receive bad news, that experience is something you will never forget. That message, when you find out your loved one's got cancer, you find out your loved one's not going to come off of a ventilator, the way that's communicated is forever imprinted in your mind grapes. And so, yeah, if we could do something about it, let's do it.
And people's perspective on like how good a clinician is, in my experience, totally anecdotal, seems directly correlated to how the communication, how high quality the communication was, right? Like you can have the same information, but you can deliver it two entirely different ways. And someone's perception of you as a clinician is going to be vastly different based on those two circumstances, right?
Mm-hmm.
Like if you're kind of blunt and don't have the same degree of empathy and compassion, and you're not approaching things sort of with a very kind of human perspective, then the relationship's going to be strained and people are going to be far more charged about what you have to say, as opposed to, just being human about the whole thing, and having a degree of polish so that you have an approach to these things, but still maintaining your kind of humanity.
Absolutely. And so what's exciting to me is the genesis of the users, like who's really benefiting from this use. So maybe speak to who Osler has been of most benefit, at least so far.
Yeah. So I think, there's been a lot of interest. And I think one of the things that we've realized is people see use cases all over. Like, it doesn't matter who I mention this to. People have, you should think about like, hostesses at the restaurant, or you should think about, service agents for company X, Y, or Z, or, you should think about, incorporating this into, palliative care nursing programs, or whatever the case is, right? Like there's just so many use cases and everyone has a spin on this, which I think is really exciting. But where we've gotten a lot of traction so far is actually with international medical grads. They have to write an exam called the NAC OSCE, and it's a oral exam where they get tested really fundamentally on their communication skills. And one of our co-founders actually went through this process of studying abroad, having to come back to Canada, going through this NAC OSCE, and really feeling like there wasn't a lot of clarity on how to prepare, whether or not he was doing a good job, what would his Canadian counterparts be doing, what would their kind of like level of communication or their style of communication look like. And there was really no objective feedback. You get a little bit of anecdotal thoughts here and there from people that maybe did okay or had at least done it before, but not really any good method. There's a few resources that may or may not help. But it seemed like that was a really unique problem for them, and one that they're high functioning, motivated people that are looking to come back to Canada to be closer to family or practice in North America for whatever reason, and are really hungry for a way to optimize their chance. And so that seems to be one of the most promising kind of like early adopters of this sort of technology. And everyone we've talked to has been super enthusiastic about this because there's just really nothing in the space that even comes close to this right now.
I mean, imagine you're a foreign trained grad, you've practiced in India for years, you want to come help out in the system, you got to write this bad boy exam. You don't get you don't get to practice.
And some people don't even know what an OSCE is. Like there's people out there that, OSCEs are kind of a part of our training system, but that's not necessarily true everywhere. And so some people might not have a lot of experience or any experience going through an OSCE type scenario. So that's one of the other things that we've been doing is we created actually a mechanism to stack all of these clinical stations. So an OSCE is an exam, an oral examination where, typically, at least in my medical school training, let me know if it was different in yours, you'd go up to a door, there'd be a prompt on the door, you read it, you have a couple minutes to collect your thoughts, you go in, you simulate a patient encounter with a standardized patient, and you try to achieve whatever the objective was of the station, whether it's a history, physical, counseling, communication station. But some people don't have a sense for what that flow is like, kind of like the rhythm of going from one station to the next, kind of like how to collect your thoughts, how to organize yourself before. So that's another thing that we've been doing is just trying to structure things in a way that's actually really high fidelity from a training perspective, so that these people, like you said, that are coming over, want to help out, want to get into the Canadian medical system, super keen, very bright, but they're at a disadvantage because they don't have the same sort of understanding of what's expected from them from the exam perspective. It sort of helps level the playing field a little bit.
Absolutely. And to reinforce that, these people could be really capable.
Totally.
Really capable to contribute to our ailing healthcare system, the lack of primary care, you name it. A lot of these people will be ready to step up to the plate. But you're going through an exam that you've not had exposure to. You don't necessarily know what to expect. You're not getting formal training in it. So now you walk into this grenade and it's like, oh my God. And now instead of potentially being ready to support the Canadian healthcare system in a short period of time, now it's a long period of time because now you got to retrain. You got to do all these steps all over again. So I just think when you think about innovation and leveraging technology, because obviously we didn't talk about it, but we're leveraging AI to be able to create these circumstances, to these evaluations for the clinician. But this is the beauty. You're now getting reps. You're now getting a chance to practice.
Totally.
And if you think about where this could go, this is where I get really excited. You think about what about a formal evaluation? Like you get your practice reps, and then maybe you evaluate the trainees and say, hey, maybe you're, instead of needing 1 year or retraining, maybe you just needed 6 months. Maybe you just need 2 years. Like the options are endless.
Totally. 100%. I mean, I think there's countless options. In terms of evaluations as well, we didn't even get into it, but you can imagine these kind of exams have so much subjectivity as well, right? Like,
Oh, of
it's a
course.
national
Yeah.
exam, but there's going to be people from many different provinces, many different backgrounds, people that have biases towards, like certain types of communication styles, people that have sort of, subconscious biases, whatever it is. But presumably, this is the same sort of rubrics and evaluation that are going to be used, and I'm not saying it's going to be perfect, and there's obviously going to be pitfalls, and people will have their own opinions on what's better or what's worse, and I respect that, but there's certainly going to be a level of standardization from this where everyone that's using it could theoretically be getting evaluated in the same way by the same system, and that's a huge amount of variability that you would potentially take out of a system.
That would be a good study, actually. Just looking at, I don't know how you would do this, but is Osler just as good as an evaluator? Because I think like getting rid of the bias would be, because there's bias. There's like, is it before lunch? Is it not before lunch?
Totally.
Is it ethnic
What's my blood
side?
sugar?
What's my blood sugar? Did I sleep the night before? All these things are going to impact your evaluation,
100%.
and so that is actually
like
an
also
underappreciated.
Like who is the person before you? Who is the person?
100%.
Like just like all the relative biases and like 100. Yeah.
And when you think of what's at stake, it's
huge.
There's
right?
kids, or not even kids. Some of them are grown ass males and females. This is their lives. This is their livelihood, and once again, an ability to step in an ailing healthcare system that needs more people at bat.
Totally. Like these people have invested tons of time, energy, money into their professional training. Now they're trying to come back to Canada to help out for whatever reason. You want to have every chance of success possible.
Have you thought about where else this can go? Like in terms of other clinician groups, or like, I mean, we're talking docs now, but like, is there any other areas that you think would be, I don't want to say low-lying fruit, but would almost have massive benefit from something like this?
I mean, I think, you could probably sit here and brainstorm, tens or hundreds of different groups, like within physicians, some other areas that have gotten a bit of traction. So transition to practice, like just re-emphasize.
What does that mean?
Transition to practice, meaning like people that are in their final year of medical school, they've kind of done all of the core learning from sort of like the physiology, kind of they're ready to go into the wards, but they just need to kind of refocus a little bit on communication skills. So whether that's like, delivering bad news, all the same kind of things that they may get evaluated on early that maybe they haven't been focusing on because they've been studying for whatever their licensing exams are. Communication skills, goals of care conversations, consent for blood products or consent for surgeries. Any of those kind of things could be applications for this, for example. First year medical students that are coming in. So like, we're talking about people that are IMGs that have finished medical school, but also like the people that are day one coming in, they have no idea what an OSCE is. They've never written one before, just taking away some of that test anxiety, right? You're not going to perform as well if you don't really have a good flavor for what to expect. Get a chance to practice. You could take it even a step before that. So, preparing for medical school interviews. You're talking about like multiple, like the MMIs that some places do, or panel interviews.
What's MMI?
Pardon me, sorry?
What is MMI?
Multiple mini interviews. It's UBC's model for, at least that's what I was familiar with, UBC's model for how you got into medical school.
Okay.
Kind of like an OSCE, there's like a bunch of stations, you get put in a circuit, and you just get asked a bunch of like random scenarios or questions at different places. Probably not allowed to say what they had me do. So like, that kind of concept. You could apply it from there to any sort of interview prep, obviously, right?
Yeah.
Like you just have to have a bit of domain expertise. That's getting a little bit outside of healthcare, even within healthcare, like any other kind of like healthcare vertical. So nursing, like any sort of specific area. So like if there's like palliative care nursing or critical care nursing or like you know or nursing, whatever the case is, you could probably extrapolate it into um, you know. I mean, I could sit here. We could spend the next hour
Yeah.
talking about ideas.
But I mean, I think this is what's exciting too. Is if there's a communication need, if there's a need to get some reps in. Like I just thinking, I know we said a lot there, but I don't know. Like if you're trying to onboard some new staff in terms of, hey, we see a lot of patients with X condition. Why don't we walk you through a couple scenarios through Osler?
100%.
Physiotherapy, social workers.
Social work. Be huge,
Oh my
yeah.
goodness, with all the scenarios that they have to deal with,
I mean, communication's like just like absolutely foundational for that.
it's foundational. Psychologists,
Yeah.
whoa, oh, that's a big one.
That's a good one, actually.
You gotta get some psychology training, and I mean, I don't want people practicing on my mind grapes, but if you could work out the kinks as a junior psychologist or early in your career, oh man, there's actually quite a few use cases.
Yeah,
Now that I
anyone
think
that's
about
doing counseling, like there's probably like counseling for smoking cessation, counseling for
it.
like, any of that kind of stuff would be another option. Like I mean, 100%, it's unlimited potential. And I think one of the core themes in medicine as well, and this is something that you've heard me talk about to some degree as well, but I mean, I just think it's there's a tremendous amount of information and data, and it's just growing rapidly. Like when you look at these exponential curves of like the amount of studies that are coming out and new information that is going to bombard people, I think it's inevitable that the field is going to move towards having more and more dependence on machines or systems to try and synthesize some of this data. I just don't think it's inevitable when you think forward like 20, 30 years. And the one thing I think that's going to remain absolutely foundational as we start to outsource certain elements of what clinical medicine looks like today is going to be kind of communication and the whole human side. And so I think this is like important now, but I think it's only going to get more important as time goes on.
Yeah, I've been thinking a lot about this because a lot of AI doomsday. There's going to be a lot of antibodies to AI in healthcare, and my colleagues won't be happy with me. But there's going to be some jobs that I think are going to be relatively obsolete, and but the ones that stick around, you're right. It's going to be the communication piece. It's like even our job in ICU. I think at one point you won't need us for a lot of what we do. Like you input the data. This patient needs to be on this antibiotic. This is the medication for their blood pressure you should initiate at this dose. We'll self-titrate this based on what the blood pressure is. We will tweak the ventilator based on how much resistance is within their lungs. Like all this in the future, I don't know how deep in the future it is, but it's going to be there. And then there's going to be at points based on, as you mentioned, data is going to be synthesized, and it's going to say, "Hey, Mrs. X, looks like the percentage of the likelihood of survival is going to be this," and then or we'll have a decision, and we are going to sit down and
we're going to interpret it,
interpret it, and say what the risk benefits are. And
I mean, you could imagine it, and like, I mean, cancer is kind of a prototypical example, like oncology to some degree, right? Like, I mean, oncology treatments are constantly getting more and more specific, and they're going to continue, presumably. I'm not an oncologist, but presumably they're going to continue to find like more and more cancer markers and ways to augment cancer treatment, and medicine in general, I guess, in a principle, is becoming more and more personalized. And once you end up with personalized medicine, like you can't expect a physician to be able to understand everything about a person, so they can't be necessarily the same quarterback for personalized medical care when it gets to a certain level of personalization, right?
mm-hmm.
And so I think as you start to approach that kind of continuum, then we're going to be forced outsourcing some amount of cognitive load on whatever sort of compute we have that's helping us sort this stuff out, right? Like we have so many syndromes like ARDS, like it's obviously not a homogeneous disease, right? And so like as you start getting more and more personalized in your ARDS management, like we're not going to be the ones that are necessarily like making all these like micro tweaks to absolutely optimize survival or whatever outcome we're gearing towards. And so I think at that point, like our job is going to increasingly become how to interpret this, contextualize it in terms of the patient, make sure it's right for the person, make sure it's right for the family, deliver that to them, and have that back and forth like interpersonal communication skills. So I think that's why this is just only going to continue to become more and more relevant over time.
Yeah. No, this is why Osler's going to take over the world. So maybe I'll let you go. I'll let you decide what direction you want to go. We could either say like, what do you think is next for Osler, or what are you excited about, and then in the not so distant future? Like, do you got any further seminars? You got meetings? Like whichever direction you want to go.
Sure. I think one of the things I'm really excited about right now is starting to see how we can integrate this into people's sort of practice patterns. I think from an IMG market, FMG market, that's kind of one of the places that we're exploring right now. We have a lot of we work with a lot of people that are coming from abroad. We have a lot of in-house experience, kind of like personal experience having gone through that, and so we're looking to try and make a bit of an impact there. I think we're really going to make a difference for people in terms of feeling more prepared coming into these kind of exams. But one of the things that I think is going to be exciting is just continuing to get some of that feedback, figure out how we can sort of optimize both the scenarios, expand into more and more useful scenarios, optimize the feedback, really start to see people integrate this in, and just that kind of like validation stage that we're starting to get into, where people are excited about this and actually starting to use it. That's where I'm really excited.
Yeah, and I must say I'm with you there, but I'm also excited about the traction. People seem to be really excited about this. Like we got back from Web Summit not that long ago, and meetings with the groups, like innovation groups in Qatar, Hong Kong.
Yeah.
There's a group in Ebenezer that seems to have some connections in Ghana. We finally got to connect, or not just in Ghana, sorry, in Africa. And we finally connected. And yeah. So I'm really excited to think that yes, we could support local innovation and local groups, but we could also, if you think about it, at an international level, you want to bring some of your trainees to North America for further training. Let's get you coached up. Let's get you to a specific level that you can integrate seamlessly, as opposed to going through those rough edges.
For sure. And it's like you said earlier, it's like a lot of these people are like, excellent clinicians. They just need like to be able to understand what the expectation is for some of these hoops that they got to jump through. Right. Mm-hmm. Like, it's just figuring out how to make that process more seamless so that it's enticing to people to come.
And I'm going to editorialize a little bit too here, and let me know what your thoughts are. But this is the exact example we need right now for leveraging technology and creating solutions with our ailing healthcare system. I'm almost a bit testy when it comes to this, because we're six. None of us have really done a startup before. We saw a need, and despite arguably barriers to execute this bad boy, we're thrown down. And what's great about this, guys, is that the tech is there that we could really create magic. People need to be leveraging the tech that there is in 2025 and beyond, because there are significant, like the barriers are low for creating solutions. And if you're willing to, more than ever. And so this is there's a bit of like a call to action to the administrators and to clinicians and to the health tech industry and the funding agencies, is be excited about it, have a sense of urgency, because this stuff will fix some of our ailments and it will save lives. Like this one less directly with the saving lives, but there's tech out there now, I truly believe, that will improve efficiency, decision-making, accuracy, precision, all this stuff. But we need to have the right mindset. We need to have that vision of like, let's go. Like, let's have that sense of urgency. Kick yourselves on the backside, and don't slow us down. You know what I mean? Especially in an area like I mean, we haven't had much in the way of barriers, but there hasn't been that push to make things happen.
No,
This has been on us.
yeah,
You know what I
really
mean?
drive it. And like you said, like the barrier to do this kind of stuff is lower than it's ever been, obviously, right? Like people should be excited about what's coming. Like there's so much that's going to happen over the next decade. And if you're interested in like innovating and getting involved in this space, like the only barrier is yourself at this point. Like you just need to just like if you don't know where to start, find some people, and there's lots of people out there that want to talk about this stuff. Like, you know, we're two of them, but you know, people are excited about this. They want to help. They want to see things come to fruition. Like they want to see people build and break stuff. Like, you know, in a test environment, see what you can do, get a sense for what's possible, and when you see a need and you can fill it, like just build it and see what happens. Like it doesn't take, you know, hundreds of millions of dollars. It takes, you know, hours and a bit of determination really at this point. Like it's doable.
Yeah, I mean, you're being nicer than I am, but I still think there's a role, at least locally, where we need to be fostering this.
Oh, for sure.
Funding it, fostering it, putting the right people in place. Like, we're going to commercialize this bad boy, but it's going to be on us.
Yeah.
We should be able to tap on the door and say, how do we commercialize this and get into more hands,
right,
as opposed to a bunch of doctors
totally
trying to figure this bad boy out.
Yeah. You know I mean, like from a systems level, having infrastructure for this kind of stuff is, yeah, I totally agree with what you're saying there. My point, I guess, is like if you're sitting at home and you have an idea, like now's the time to like don't just let it be an idea. Like there's ways to do stuff about this now.
Yeah, that's true. I mean, that's why I know we're focusing on Osler, but we also created that Lionheart innovation for that reason. Knock on our door. You got an idea that's going to impact people's. It's going to impact healthcare. It's health tech related. Even if it's not health tech related, if you have an idea that can impact lives that you would need help with, whether it's finding clinicians, whether it's finding researchers, whether it's finding engineers, computing software, whatever it might be, knock on our door. Because like I think, like I said, the barriers to try and create this stuff is low, but we're trying to accelerate the process.
100%. Yeah. There's a huge need for it right now, right? Like, yeah.
The need is, I mean, you want the list? Surgical wait times, ER wait times, primary care, preventative health measures, access to clinicians in general. There's tons. And like I said, I don't know, this post would have probably been, it'll be before this comes out. So I did a post on more on a leadership lens, but more towards people involved in healthcare. One of the best tools that you could use to really be productive and to move the needle is urgency, whether it's false or real. Yeah. We saw it during the pandemic. You saw that stuff that would take forever for us to pivot from, all of a sudden we were doing it. Anticoagulation, delayed intubations, all this stuff, because there was urgency. Yeah. And so I think there's legit reasons for urgency now, but even as a tool, as a leader, creating that urgency so there's that buzz, there's that energy, there's that, let's not just sit on our hands. There's a bit of Parkinson's law where now you feel like you could get things done in a short period of time. I think we need this now, and I think we need our leaders to be bringing that level of urgency. Because I don't know about you on a daily basis, I don't feel the energy of the lack of primary care, the lack of access to, or the long emerged wait times, the lack of training, foreign trained grads. Like nothing's changed in I don't know how long. So I don't know. I'm totally going off the rails here, but
yeah. But I think you're right, and like there is urgency too, because there's people that want to do this stuff, and we need people to be doing this stuff. Yeah. Right? Like there's both sides of the coin. We just gotta find a way to make it happen.
Yeah, and it starts now. This is why we got Osler in the mix. That's why we got Dr. Brett Hryciw in the mix. So, but thanks for joining me on the show. This is I have a feeling this is not the last time you all will see Brett. We got a lot of things that we're working on together through research, through Osler, through Lionheart, and it's great seeing your genesis. I feel like you're gonna you're in the early stage of your career, but you're going to amount to some great things because you're thinking ahead of the curve, which is what we need more of in healthcare. So thanks for joining us.
Just good mentorship.
Yeah. Do we tell? Is Osler the website easy to bust out? I think
Osler AI, OSLER AI.ca.
Yeah, beautiful. Thanks for joining us. We're gonna see you all on the next one. Brett, this was killer. Thank you, bud.
Cheers.